Immune checkpoint blockade, Ipilimumab and the CTLA-4 receptor. In 2015, there have been an estimated 1.7 million new cancer cases diagnosed in the United States. Put into perspective, that's about 3 people per minute. Chemotherapy, probably the most well-known treatment of cancer, is not the best option to kill cells both healthy and bad. Therefore, there's a great need for novel, more cancer-specific treatments. But first, a little story. In the 13th century, Peregrine Laziosi had a lesion on his tibia so large that it broke through the skin and became extremely infected, so the doctor decided to amputate his leg. However, by the time of his operation, his cancer had spontaneously regressed, caught in the crossfire of his body's immune response against the infection. Laziosi's case is not unique, and there have been many other reports of the spontaneous remission of cancer after infections with various diseases like gonorrhea, influenza, and malaria. However, since the FDA would never approve of deliberately infecting people with terrible diseases, how will we activate the immune system in the modern day? In order to answer this question, we must first understand how the immune system attacks cancer cells. First, the major histocompatibility complex.
Every cell has an MHC, the major histocompatibility complex, which displays peptide fragments known as antigens. Every person has an antigen that is specific to themselves and the immune system recognizes as self. However, don't cancer cells look just like the body's own cells? No, for example, cancer cells have many genetic mutations, some of which might result in a mutated antigen that the immune system would then recognize as foreign.
Now, here's how T cells are activated.
During routine surveillance, antigen-presenting cells, APCs, take in membranes from cells, processes them, and presents the antigens to the T cells. Once the T cell receptors, the TCR, binds to the MHC complex on the APC, there needs to be activation by a second signal. For this to happen, the CD28 receptor on the T cell must bind to the B7 receptor on the antigen-presenting cell. The T cell is now fully activated.
Finally, CTLA-4 downregulates the immune system.
Once the T cell is activated, CTLA-4 is upregulated into the T cell's membrane in order to keep the T cell from becoming overly active. CTLA-4 has a much higher binding affinity for the B7 proteins than CD28 does, so it outcompetes CD28 for the binding site. The binding of B7 to CTLA-4 inhibits the synthesis of interleukin-2, inactivating the T cell. Shown in this pie-mall visualization is the binding of CTLA-4 to the B7 protein, where B7 is in red and CTLA-4 is in green. The CTLA-4 protein has an extremely high affinity for B7. The complex has a KD of 12 nanomolar, which is much smaller than B7 CD28 complex KD of 200 nanomolar.
With all this knowledge, we can now talk about Ipilimumab.
Okay, so now we know that this receptor, CTLA-4, competes with CD28 in binding to B7, and that the binding of CTLA-4 and B7 inactivates the T cell. So how do you think we can stop the T cell from becoming inactivated? Simple. If we could somehow prevent CTLA-4 from binding to B7, then we wouldn't have to worry about the T cell becoming inactivated. It turns out that there's an FDA-approved drug, Ipilimumab, that just does that in patients with advanced melanoma and other cancers. Ipilimumab is a monoclonal antibody that binds to CTLA-4, so that it can no longer bind to B7. CD28 can thus stay bound to B7, and the T cell remains active. This is known as an immune checkpoint blockade, and allows the immune response to be active for much longer than it would normally be to better fight against cancer cells.
It is important to keep in mind that Ipilimumab is not a panacea. Overstimulating T cells may allow you to combat cancer, but may also turn them against your own regular cells. For instance, Ipilimumab is known to cause autoimmune side effects like severe rashes because it blocks the body's natural defense mechanisms against autoimmune diseases. However, side effects aside, Ipilimumab has done quite well in clinical trials. As shown on the graph, in the final trial for FDA approval, patients who took Ipilimumab had a survival time of 10 months, versus 6 months on the experimental GP100 cancer vaccine. So, Ipilimumab works pretty well, but where is future research headed?
Because T cells express multiple inhibitory receptors, one idea is to use combination immunotherapy, in which we block T cell inactivation at multiple sites. In an analogous example, PD-1 is an inhibitory receptor that is just like CTLA-4 and inhibits the T cell when it binds to the PD-L1 receptor on the APC. Thus, anti-PD-1, an antibody, can be used to bind to PD-1 in the same way that Ipilimumab binds to CTLA-4, preventing inactivation. Current data suggests that blocking both CTLA-4 and PD-1 is even more effective at allowing the T cells to remain active.
In conclusion, immune checkpoint blockade is an extremely effective means of treating cancer because it means that we require no knowledge of what specific antigens cancer cells express, and because it is theoretically effective against all types of cancers. Cancer cells are less like soldiers of an invading army, and more like traitors within the ranks of a human cell population. So anything we can do to help the immune system recognize and destroy cancer will bring us one step closer to eradicating cancer completely.